Okay, so welcome everybody to Navigating Care Decisions After Discharge from the Hospital. We are pleased to have Evie here from our clinical resource team at Danbury Hospital. I will let Evie introduce herself and talk a little bit about what she has been doing. She comes with a great deal of knowledge, and we are thrilled to have you here today. So thank you, Evie.
Thank you. Thank you. Can you hear me okay?
Yes.
Okay, great. So thank you everybody for signing up. And I see some familiar names, but welcome everybody else. So yes, I'm a clinical care manager here at Danbury Hospital now for the last 10 months, but not new to the speech that I'm going to give and the population that I serve. But I was a social worker in nursing rehab for 25 years. And I also, at the same time, was doing home care social work for a couple different agencies per diem. And I taught a class at Western Connecticut State University on aging for about 6 semesters in the evening until they decided no one wanted to take an evening course on Monday night. So they did away with it, which is unfortunate. But and then I've done case management for myself and to help out some other geriatric case managers in the community. And my recent gig is a realtor. So that's my fun part. And hope to have a senior real estate specialist credential to that, since that's my world. So I bring a lot of a variety of areas of social work and care managing. And the main subject right today is navigating care decisions after discharge. So I'm going to try to hit everything that you may have a question on. And I probably have to close this out about 1:15 because I have a Teams meeting at 1:30. I have to run on the other side of the hospital for. Currently on the acute rehab team floor, so I have to get to that. But I'll be more than happy to go through this. And if you can save your questions to the end, maybe you can jot a note for yourself on what you want to ask so that you don't forget. All right. So I'm going to start out with basically at the hospital, and this may cover also a patient that might be at a nursing home rehab, because the social worker's role is very similar to mine. And I've done both, so I can definitely say that in comparison, they're very similar. But when someone is coming in the hospital, the big question is where to go after that. So some people are discharged without having any needs, such as home care, medical equipment, nursing home, private care duty, help. There are many people that are discharged without that. But every person has a case manager assigned. Sometimes it's a social work case manager like myself. Sometimes it's a nurse case manager. We do the same things. And the only differentiation is if there's a social worker, sometimes they have a little bit more difficult cases that require a social worker, and the nurses do the utilization review. So they're basically stating whether someone is meeting a certain criteria for billing for the hospital, whether it's observation or inpatient. But when it comes to discharge planning, we do the same. So you're a patient in the hospital or a loved one's in the hospital, and let's give a scenario. I mean, because obviously if anybody in the hospital did not need anything, you probably wouldn't be on this Zoom call right now. So the question would be, what happens? Well, the case manager will go in, do an assessment, talk about, your home environment, are there steps, what's your bathroom like, who's your caregiver, do you need caregivers, are you home alone, do you have resources, a support system, etc. We take a look at that first. When it comes time for discharge, we're planning from day one right till the day of discharge, whether someone needs referrals, again, to home care, non-home care, medical or non-medical home care, to an assisted living, to short-term rehab, to a long-term care hospital rehab, to possibly just even for outpatient rehab. Again, if you need nothing, you see us, wave goodbye, we wish you well. So we put this in place when people are asking us a lot of questions, like who pays for that? And that's a big question, right? Because that also determines the discharge plan. It's great to go home, but what if you have a need not to be alone? You need supervision and there's no one there. Well, again, we wind up saying, okay, how old are you? So that matters. Many people from the age of 65 and older have a lot of resources available under Medicare or managed Medicare. Medicare being traditional, and usually you have a supplemental insurance. Home care, like a visiting nurse agency, that's covered under Medicare Part A. Okay, so there's no pre-qualification for that, such as a hospital stay, like there is for a nursing facility. So we'll give a scenario, a couple different scenarios. Patient A. All right, so patient A needs to go to short-term rehab. And patient A has traditional Medicare. Medicare usually will pay the first 20 days at 100%. And day 21 to day 100, approximately 80% of the daily rate is covered. And then the supplemental insurance, whether it's like AARP or Aetna or some other insurance, or if they have Medicaid, which is state funded, it's also referred to as Title 19 or Husky, that would pay the copay, or something called Medicaid QMB, which is qualified Medicare benefit. And that only pays supplemental, like the co-insurance part of it. It doesn't cover the whole thing. So patient A goes to a short-term rehab and they stay for a period of time. They will also receive a social worker at that end. And that person will continue with we started. But they'll go a little bit more in depth because the discharge now to home is happening from there. Now, are you guaranteed 100 days? No. If you plateau, if patient A plateaus with, okay, this is the best they can be with their rehab, then a discharge plan is put in place. And if they're fortunate enough to go home, what they need is put in place and they go home. If they're not making enough gains, like I said, plateauing, or they meet their goals much sooner, then they can go home sooner. What happens though if patient A doesn't recuperate enough to go home, but Medicare is not going to pay any longer because they've plateaued? So who pays for that? That's a big question. So if there's private funds, of course, then there's a private, sorry, I'm getting a little, if there's a private funding, then there's a daily rate that you'd have to pay at the nursing facility. And that rate can vary from 300 something to 400 something a day. So who has that kind of money? Some people do. Some people have sold homes and now they have some money in the bank, or they did very well in business, whichever. So there might be some funds, and maybe there's not funds for a while. Maybe it's a short-term amount of money that they have, and then they would have to apply for state Medicaid. State Medicaid looks back about 5 years of bank statements, ownership, if you sold anything, transferred anything. So I know some people want to transfer money to their kids. There's tax penalties where you can only transfer so much, but if it's within that 5 years, they're going to look at the amount of what's transferred, if it's a house or if it's finances, etc. And then the question is going to be, is there a Medicaid penalty? But they're going to determine that when they ask for all the paperwork and figure out if there's a penalty. So keep records. I would be very cautious about transferring money unless you talk to maybe an elder care attorney, someone to advise you. Definitely don't go by what I'm saying, because of what I'm saying right now is general. It's not taking in consideration your specific plans, your specific situation. So again, this is just a general statement. Just be careful with that. Sometimes people have too high of an income to qualify for Medicaid, in which case then you can set up a pool trust, it's called, with an elder care attorney that could divert some of that income into a trust only used for home health care eventually, but can bring that income level down if it means meeting criteria for a program. So patient A goes to the hospital. Patient A is set up with home care. They go with some VNA, okay? Just to let you know, there are choices. You do have choices as to which VNA you go with. And there's preferred relationships, but there is a star rating you can go to. If you go to Medicare Home Care Compare, you'll see, just like with facilities, Medicare Nursing Home Compare, you will see the different names of the facilities, different names of agencies. You'll be able to see their star ratings and whether their overall star rating is sufficient for you. Sometimes you may hear of a great place, you may hear of a not so great place. Times have changed between places, don't you know? So do due diligence for yourself and do the research on these places, because there are different ownerships and different changes that take place, and those star ratings go from 6 months to 6 months, and they can change. But let's go back now. Patient A goes home with a VNA. Starts with nursing. Within, they have up to 48 hours to see a patient, to open a patient up as an admission. Then perhaps the next day or two, physical therapy may start, occupational therapy, home health aides are covered as well, and social work. However, there's a little glitch. Home health aide and social work is not covered by themselves, but if an occupational therapist can't open a case or be in there, can't open a case, okay? But nursing and physical therapy can. So you need one of those two at least to have a VNA covered. Now, as long as as long as physical therapy or occupational therapy are in place, that will cover the home health aide, that will cover the social worker if that's needed. The occupational therapist, if that person is in there, they can stay, even if the other two that start out, the nurse or the physical therapist, are done with the case. They can remain, but they can't open a case. Either can speech therapy. But again, if you have the first two, at least you can get the others covered under traditional Medicare. So patient A has some rehab at home. Maybe they had a knee replacement and they only needed about 5 days at home as a bridge between home and outpatient therapy. Because home, you're going to have a certain amount of resources available. You'll have the steps that you have perhaps, or equipment that you may have in your home, and some exercises and some walking. But if you want a little bit more strenuous therapy and you can get out to outpatient, then that Medicare will cover that under Medicare Part B, not Part A. So this gets very overwhelming, by the way, and confusing, because I've been doing this for years and years and years, and I can be speaking about this, but your mind will probably be blown away at the end. So I'll hope to cover as many things as I can in this time frame. But Medicare A, going back to that, covers nursing facilities and the hospital. There's no cap on how much time Medicare will cover in the hospital. And normally you need a 3-night stay overnight at a hospital to cover in the nursing facilities. During COVID period, we had there was a waiver because there were so many people needing placement that we couldn't wait for 3 days. So there was a waiver for that. If you're in the nursing facility, again, you have the 20 days and the 20 days at 100%, and then the 80 days at 80% or so. Again, it could be shortened depending on the goal, if it's met or if the person plateaus. If you're home, however, I just want to jump to this while I'm talking about Medicare coverage and home care. If you're home and you need home care, like you've had some changes in medications, you went to the doctors and you've been having some dizziness or change in medications, or you just need a little tune up with balance, or you're going for a surgery, but you want to get stronger because that helps with your recovery, then your primary care doctor can also write an order for home care. You don't need any overnights in a nursing facility or any overnights in a hospital. You just need an order and you need to have insurance. Another little glitch to Medicare Part A at home. You need to be homebound. Homebound criteria is basically that you can go out for 3 reasons they have come up with. 1, to doctor's appointments, because we know there's plenty of those. 2, religious services. And 3, this is going to sound crazy, but to get your hair cut. And the reason why they say that is because it's also part of psychosocial well-being. The better you feel about yourself, the better your health, your recuperation can be. So religious services and having, appearance fed, taken care of, can help the overall wellness of your recovery. The amount of days patient A can have at home under Medicare Part A depends on how the patient's doing again, but there's no 100 days max. There is a period of time. Usually it's 9-week certification period. And there's an assessment done by the nurse, therapist, whoever, and that the order for however many days and however long they're going to treat the person is then sent to the doctor's office. If the patient has not seen that doctor in quite a while, they're not going to approve orders. So it's pretty good to get regular checkups, even if it's just a wellness check. And so then you want to have a discharge with everything safely ordered. You want to have a doctor approving orders so that it's paid for. We talk about patient A doing well, coming off therapy, everything's great. Or patient A maybe had that 5-day or so window and now is going to outpatient therapy. Again, Medicare B now kicks in. Medicare B covers the doctor's offices, covers outpatient therapy. And depending what plan you have, it covers only so long. And then there may be a copay to that. So you can get that at home as well under an outpatient. If you're in an assisted living, you can get Medicare Part B to pay for therapies that sometimes are in the assisted livings. There's usually a gym or some outpatient therapy, but you have to exhaust your Medicare Part A first services, and then you can switch over. So patient A, great, recovered, doing well. But let's say patient A took a turn for the worst, not as good as we expected. And there is within 30 days of discharge from a nursing facility, 30 days that they can go back to that nursing facility. If they haven't used all their 100 days, they can go back with doctor's orders and get picked up on Medicare A again for the remaining numbers. So if they left on day 30 of Medicare, or 31, 32, they can pick up on day 33 or 34, whichever day. So they pick up in that 100 days. But if you're past that 30-day window after discharge, it's not going to cover you getting back in. You would have to have that 3-night hospital stay again. Also, not only do you need that 3-night hospital stay again, you need now 60 days from the time that you were in that facility for Medicare to start the clock again. Can you go back in? I mean, no one's going to say no if you have money to pay for it. So there's always the private funds, but there are some glitches. So you want to work with the admissions coordinators of a nursing facility, and that's after discharge from the nursing facility. Otherwise, the hospital case managers are working with you. So I hope I'm clear so far, but remember, if you have any questions, jot it down and Miranda will take care of that for me, and I'll try to answer those at the end, or you can speak up yourselves. So now let's go back to patient A. to the side. Now patient B comes in. Patient B is in the hospital. They had a traumatic brain injury. They are on a ventilator, perhaps a tracheotomy, needs a lot more care than maybe a nursing facility can handle. So there's long-term care hospitals, such as Gaylord or Hospitals for Special Care, in New York, Burke. So those are three common ones that we've heard of. That's where they can stay for acute rehab, but it's for a longer period of time. And they're not expected to make quick recoveries, but they have to meet, again, criteria. So if they're on a lot of oxygen, 50 liters, which yes, there are people on high flow heated oxygen at that, especially during COVID time, there were some people that met that criteria that just couldn't get to a facility because they were not well enough. They were on too much oxygen beyond what the facilities can handle. And they didn't need to stay here any longer though. They were stable for discharge, but they needed more care. That's where those other facilities would take place. And the care manager would help arrange that. But let's say now patient B has managed Medicare. Dun, 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 dun. Everybody has been trying to sell you. You must, if you're of age to receive all the advertising in the mail around close to the time you're going to become 65, or someone you know, perhaps getting flooded with advertisements or even on TV. Managed Medicare is a replacement for traditional Medicare. Managed care almost acts like an HMO in a way. So some popular ones are United Healthcare, Anthem Blue Cross Blue Shield, or Aetna. Those are some common ones. Now you have a nurse case manager who has to give authorization for everything, for how long the hospital stay is going to be, for if someone wants to go into the acute rehab in the hospital, such as where I'm working right now, we have to get pre-authorization. It doesn't count as part of the hospital. It counts as a rehab, but we're just within the same building. So then the RN case manager will review the documentation that we send. Nursing, physical therapy, doctor's notes, etc. They determine now how long you're going to be in that facility. Now, it might be Burke Rehab. It might be maybe patient B is starting to improve and can go to a skilled nursing rehab instead. Either way, if you have managed Medicare, patient B's fate belongs to that case manager. They usually will approve up to 5 days at one time. And then you're probably like, what happens after 5 days? Because everybody's hanging. Well, the case manager or the social workers in those long-term care hospitals or the acute rehab where I am, or the nursing facilities, someone's responsible now for sending the documentation in. Sorry.
Attention please, rapid response, 7 Tower acute dialysis. Maybe attention please, rapid response, 7 Tower acute
One of the many announcements we hear. Anyway, somebody's responsible for now sending in the documentation to that RN clinical case manager who's going to review your case, or in this case, patient B's case, and going to determine now how long length of stay is approved for. Again, they usually start 5 days. So someone is at day 4, day 5, sending in the most recent documentation showing what has been happening, showing the gains, showing the goals. Then we have to wait for them to call us back and fax us back with the next set of approval dates, if they feel the person needs to stay there. If they don't, again, that's why discharge planning starts from day 1. You have sometimes dual plans being made at once. Okay, patient B, if this doesn't pan out and you have to go home, or you don't get approved for the long-term hospital, but you do get approved for the skilled nursing facility or short-term rehab, then we've already made referrals to backup places. Because once they're not covered anymore, we have to get that person discharged. You can appeal it with Medicare A or Medicare Part A, the traditional Medicare and managed Medicare. You have a right to appeal. You should be given notice within 48 hours, usually, sometimes it's the day of an appeal phone number. If you feel that you're not quite ready and that you think you can be in that location a little longer, there's a phone number to call for a company, at least in the hospital. The phone number to call is to a company named Kepro, and Kepro just determines, once they request all the documentation from us, we send it all over. They determine now if they agree with you, yes, you can stay longer, or no. They side with the decision of the doctor that you are stable to leave this level of care. If you have to leave this level of care, you have until noon the following day. So a little pressure again to have that discharge set up. Same thing for the nursing facility. Now patient B has moved on. Patient B is now managed care said, okay, 5 days or 7 days at this location, this other location beyond the hospital. Around day 4, day 5, the paperwork sent in, patient needs some more time. Great, more time. We're getting stronger. We're getting stronger. Patient is then nearing meeting their goals. They get this Medicare denial that says within 48 hours, you're going to end your stay here with us, and your insurance will stop paying. Again, this goes for Medicare, non-Medicare, managed care. Again, you have the right to appeal that decision. Then a decision is made. Then you're either going home or you're staying a little longer. Again, you can go home with visiting nurses, with private caregivers to make up, because visiting nurses, just to let you know, some people may have a little bit of question as far as what they do. They go in, they do an assessment. They see how much care you need. The first assessment's about an hour, hour and a half usually. They go over medications. The number one reason why people, well, there's 2 reasons why people can be readmitted to the hospital. And one is that their medications are messed up from what they were discharged on to what they have at home or they're taking at home, or they just don't understand the directions and they're taking too many, they're not taking it enough, they're not taking it timely. They're using old prescriptions and new prescriptions. So that's one of the reasons that a visiting nurse is great, because they're going to reconcile those medications with the primary care doctor, and they're going to make sure that what you're discharged on, what you have, and what your last were ordered, that there's a decision made on what you should be taking, and then that's what should be in place at home, and the directions from the nurse will be reinforced. Physical therapy will come out if you need it, and physical therapy will do an assessment. Occupational therapy. Physical therapy usually deals with lower body. Occupational deals with upper usually, but many times they cross over. So occupational therapy is dealing with bathing, dressing, cooking, how to do those daily tasks that you have to maintain yourself at home to survive. Physical therapy is going to help with mobility, okay, with walking, with strength, and sometimes getting in and out of a shower or bathroom is overlapped between the two. It might be car transfers. It might be walking down to the mailbox if that was your routine before, taking the garbage out, whatever that goal is and your responsibilities were, they try to get you back to that prior level of functioning. Sometimes though, it can't be. Sometimes therapy is usually out twice a week. Nursing might be 3 times the first week, second week, maybe twice, maybe once a week. Again, all depending on the person's needs. If they can't be alone, or they need some additional assistance or additional nurses' aides, whether it's companion, a homemaker. A companion is basically doing supervision. Homemaker's doing some chores. Maybe they're doing housekeeping, light housekeeping. They're doing meal preparation, laundry, maybe running people to the doctor's appointments, assisting in those ways. And then a PCA, patient care attendant, or assistant, or nurse's aide, CNA, certified nurse's assistant, depending on what is in place at the private non-medical companies, those people can help supplement. Who pays for that? Not Medicare. Okay, so now we're going to who pays for the extra. I can't be there to help mom or dad or my spouse, etc. I have to work. Love to be there, but I can't afford to. Well, okay, let's talk about non-medical. Who pays for that? If someone has a long-term care insurance, and you would know that because you're going to be paying quite a bit per year to have it, but that can pay towards an assisted living, that could pay towards a nursing facility somewhat, but that can pay also towards your home health aide at home, or homemaker, or companion, etc., for the non-medical home companies. So we'll give a, you may have some in mind that you've used in the past, but there are some, Bright Star, Visiting Angels, Synergy, At Home Care, Nurses, Danbury Nurse Registry. I mean, there's many in the area, okay? So those are non-medical, companions and homemakers, live-ins for the elderly, etc. So it's not a VNA, not a visiting nurse association that takes insurance. It also, now some of the VNAs are not named as a VNA, such as, and I'll throw a couple names out there, Amedisys and Alara Caring, Foothills Home Care. There's a lot of different VNAs, visiting nurse agencies, but do not have that name as part of their title of their name. So you just have to find out, is it skilled care nursing or skilled care visiting nurse that takes insurance, or is it non-medical? So the non-medical, if you have the long-term care insurance, great. There has to be a care plan put in place. There has to be doctor's orders, etc. for it. It has to be approved for billing. Sometimes the Veterans Association will pay. If a veteran served during wartime and they have to have certain needs, and there's certain criteria financial, but if you check with the VA services, there's something called aid and attendance. And sometimes they can pay for assisted living, a portion of it, not all of it, and can go towards home care as well. What if the spouse of the veteran needs the help, but the veteran doesn't? No dice, sorry about that. However, if you are a widow or a widower of a veteran who meets that criteria of serving during wartime, and then you fall on that certain financial criteria, which you can, call a Veterans Association to talk about this, but then you would be able to receive that aid and attendance. So let's say patient B now is going home, needs extra care. Maybe there's family, maybe there isn't to help out. Maybe it's an overnight that they need, or whichever the issue is that comes up. You could probably have some scenarios in your own lives that you can think of right away that you would think, oh yeah, definitely mom, dad, spouse, friend needed that service. So then, and some people need live-ins, they need 24-hour care. So that would be in place. And then they would assist with the needs of the patient, of your loved one, of the care, for the care that's needed. So not only does the long-term care insurance pay for that, sometimes Connecticut Community Care pays for that. That's another program in Connecticut. Other states have different programs, and they're named, I don't even know what their names are right now, because I usually wind up dealing with all Connecticut. But Connecticut Community Care is through the Home Care for Elderly's or it's through the Area Agency on Aging, Home Care for the Elderly. And a referral is made. We have we have that option too in the hospital to ask for this assistance if we know and we have a little time to ask for it. We have someone from Connecticut Community Care who then ends up paying for the services. There's a budget and it's partially state and federal funded and partially private funded. So the referral goes to the area agency on aging. They send it off to Connecticut Community Care. Sometimes it's called Southwestern area for the aged, for the lower part of Connecticut. So Connecticut Community Care will do an evaluation and determine whether you need, if you meet the criteria, they put together a care plan, which could pay for some of the needs, whether it's Meals on Wheels, whether it's an emergency response system, if, you know, when the buttons, I fell and can't get up buttons, whether it's for a homemaker, companion, or live-in, maybe even for adult daycare. There is one in Danbury, there's one in Newtown. Okay, so sometimes they pay for that. So, you know, you look at what's going to be the best, what options, what is going to financially be the most suitable to keep a person growing older in their own home. So there's certain agencies though that have contracts with Connecticut Community Care. So not every agency does, but some people are paying privately for that. Okay, if they don't have services that help with payment, then it's usually a private pay situation, which in many cases is a lot less expensive, in all cases, and a lot less expensive than nursing home care privately. But sometimes you have no choice. Sometimes a person needs two people to transfer them, or they need, or the finances are just not there enough to keep that person there long-term. Then they might have to go to a nursing facility, use their funds, and then apply for Medicaid, the state-funded insurance, and that would pay for it. Some people, okay, what else? How else do you pay for this? So some people that have paid on their houses can do a reverse mortgage. Again, you have to be 65 or older for that. You have to have a need, and then you would get an income from your equity in your home. You'd get a check that you can then pay for your own home care. With Connecticut Community Care Services, they have a social worker that manages for you, instead of you taking the money from your home equity, you know, or your equity in your home under a reverse mortgage, so that you can maintain your home, still living there. Let's say you don't have that. Let's say you rent instead, or let's say there's just not enough equity in your home, or you don't own the home. Then if Connecticut Community Care is in there, they're sort of loaning you their care. And at one time they were able to recoup money from the house if the house was ever sold. And that's partly how they fund their services. But if you're in an apartment, you don't own the apartment, how do they get their money back? Not from you, not from your family. It's just, it's a state and federal funded program too. It's again, another way to keep people out of a nursing facility long-term, because that costs everybody, including the state, a lot more money. So, you know, a lot of people think when there's a spouse that, oh, I can't apply for Medicaid, I'm going to lose everything. They're going to make me sell my house. I'm going to be homeless, you know. And some people don't request the help because of that. And it's not true. The spouse in the home is allowed, you know, there's a formula that the state looks at. So if a spouse A will just, I know this is side noting, but it all leads into, it all feeds each other. You know, if you're thinking about keeping a person at home and you're married, the spouse in the nursing facility, there's a debt, right? $14,000, $15,000 a month to pay. Let's say you have $100,000 to your name, yours and your spouse's, not counting your home, not counting a primary car. Okay, now assets, I will tell you what they count as assets. I'll go back to how they split it up, but what they count as assets when you hear of that is money in the bank, anything that could be liquidated, such as checking, savings, IRAs, mutual funds, CDs, 401ks, money under the mattress, although I don't know how they find that out, but they're not going to go snooping around for it. But they will look to see if there's a large amount of money taken out of the bank account, right? Because they're going to look back 5 years. So financial planning might be good, or that the elder care attorney, but they're going to look at everything. Now, you may not think of this either, but a life insurance can count as an asset. Term life cannot be counted because it's only paid to a beneficiary upon death. You yourself can't use it, right? You can't cash it out. But whole life or universal life insurance that you can borrow money against, that counts as an asset. And they only allow you to have a certain amount of cash value to that asset. Some people cash that out and just put the money towards a funeral fund with a funeral home. That money in a funeral home is not counted as an asset because it's irrevocable. It goes towards the ultimate time that we all will face one day. And that's whether it's burial or cremation, you still need a funeral home involved. So we know costs of everything goes up. If it's in an irrevocable fund with a funeral home, that's one way to preserve some of the funds that you have, and it builds escrow there that goes towards costs of taking care of the deceased person afterwards. But anyway, that's so, I'm going to lose my train of thought for a second, but let me give you the criteria for Connecticut community care. Because, there are a number of people that can't afford home care. They can't afford, I don't know, maybe they have a spouse, but they just need a little extra care. The spouse can't do it. Or sometimes both people, maybe they're not married, but both people are living together. Maybe they both need care. And very much do not want a facility. Or let's say, there's a transfer of funds and we have a little issue here. It might be a little less expensive to take care of someone at home then. In either case, you have to be 65 and older. You have to have at least 2 needs, not counting an instrumental need. That an instrumental need and an ADL, which is activities of daily living, there's a difference between that. So the activities of daily living needs is what they're looking at. You need at least 2 of those needs, and that might be bathing, dressing, cooking, doing medications. So anything involving your physical care, and nutrition is, meal preparation is part of your physical care, and so is medication, because in many cases without that, you may not be at home, you may be in the hospital again. Other needs like instrumental needs might be chores, might be driving to appointments, might be, I'm just trying to think of any other, grocery shopping, laundry, those other items, they don't count, even though the person may need it, but you have to have at least first 2 of the care needs, okay? And then you have to have less than a certain amount of assets. I don't know that, I'd have to go back and just check the latest, but don't quote me on this amount, but it's something like for a single person, it's about $30-something thousand. I want to say maybe 35,000 or so, 32,000. It changes every year. Again, not counting a house or a primary car. If you have more than that, they're going to count as an asset, including all the places money can be. The mutual funds, the banking, all the checking, savings, et cetera, that I mentioned, all looked at as an asset. Some people make too much money to cover them per month. They don't really look at your debt that you have to pay. But again, if you do a pool trust, perhaps that can help you meet the criteria. So 65 and older, have at least 2 needs and meet the criteria financially. If you're married, it's like 50-something, 60-something thousand. Again, don't quote me today because I don't have that amount at the moment, but you don't have to have only $1,600 to your name, which is what Medicaid recipients have. so they can own a house, but if if they're just living paycheck to paycheck or a social security check to social security check or whichever the income is, and it's going out, if they month to month only have $1,600 or less for a single person or one person needing the care, then they could qualify for that. They may be in a nursing home too, that, their money's going down, 60,000, 50,000, blah, 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 but you're not going to be able to be active on Medicaid until you hit that $1,600 limit, that asset limit. And that's why we encourage people to use it on funeral costs ahead of time, because where are you going to get it later? It's going to be a family member, it's going to be your spouse that's going to have to figure this out. So sometimes planning that way ahead of time, even though it's something you don't really want to think of, it does help when the time comes. And I'm trying to think, let's see what I missed. Yeah, okay. Patient C. Patient C goes into a nursing facility from the hospital, doesn't do well in therapy, or maybe they use the whole 100 days. They were making small gains, small, or they had a feeding tube, which can cover the whole 100 days. Let's say they're there the whole 100 days or less, they're taken off Medicare. What happens? They can't go home, not even with a live-in perhaps, or maybe there's no funds for a live-in, they can't qualify for a live-in, they're not of age, whichever the scenario is. I've been in situations where the person doesn't have a home to go back to because somewhere along the line, they forgot to tell us that they were being evicted, or the person that was taking care of them passed away or wound up with dementia, or something happened where the caregiver physically can't be there to take care of you. Again, there's alternatives for different things, different scenarios. And, I'm not going to, between patient A, B, and C, I'm not going to meet everybody's scenario. That's where sometimes having a senior care advisor, we're called geriatric care managers in the community, or senior care managers. Sometimes, it is private pay for that only, but sometimes having that advice can help you with taking all the different scenarios that you may not be aware of. Because again, I'm giving you a picture here, snapshots, but when it comes to your specific situation, people get more in depth and can guide you better. Now, if you don't have the finances to hire a senior care manager, geriatric care manager, if the person is in a setting such as a nursing facility or a hospital, utilize the social workers, utilize the case managers to help you guide through this. That's what they're there for. Now, assisted living is another alternative I haven't talked about much. Assisted living is private pay too. You can come and go from assisted living usually, unless you're on a dementia unit or a secured unit. So let's say the person doesn't really, is basically walking, talking, but they're very forgetful, too much for the spouse, or there's not enough funds to pay for a person at home to take care of them. Or the person at home just can't sleep because they're up at night, or they're working, or it's a daughter or son, whichever the scenario is. For whatever reason, assisted living is the alternative to a nursing facility, providing that all their care needs could be met, providing there's financial ability to pay for it. The Veterans Association, like I said, if you meet that criteria, can help towards it. Not all of it. Medicaid doesn't pay for it unless you're in a facility where they had this pilot program that covered part of the cost. It might pay for the aid part, the physical part, because some of the coverages are a la carte. Some assisted livings give you a blanket cost or charge for everything, but sometimes it's the basics. And then if you need this amount of care, it's level 1, more care level 2, maybe ultimate, heavy duty care, but still maintaining that environment, maybe level 3, not sure. So you'd have to check with the assisted livings on that. Some people are very independent and they just don't want the hassles of home care, taking care of your home anymore. They want to live a lifestyle. They don't want to pay taxes and deal with mowing the lawn and shoveling and car maintenance and all that stuff. They don't want to be isolated in the community. They want other people their own age. They want activities. They want to be taken care of. They want to have their meals prepared at like restaurant-like style menus. They want to make choices. There's even alcohol there. So maybe they have their own car and they can come and go as they want. It's your own home, it's considered. Some people need a care plan in place that need some home care there. So if assisted living is your home now, you can still get a visiting nurse agency in there to assist you under your insurance. You can still get non-medical in there if you need a little extra care at night or a little extra, maybe you need a live-in there as well, but you like the environment of an assisted living instead of a nursing facility. That's all great. The only thing with that is when your private funds stop, whether it's the long-term care insurance, private funds mixed with Veterans Association, or maybe some of the Medicaid assisted livings that have the Medicaid paying for some of the physical care, but not the room and board. Let's say money starts to run out. They will help you, by the way, try to plan ahead for placement after that, because Medicaid state aid does not pay in full, in totality, for an assisted living. So then people wind up seeking out nursing facilities. Or maybe they say, you know what, this was a nice short-term stay. We wanted to check it out. We wanted to do a respite for 30 days or so while we were away on vacation. Someone can take care of mom or dad or spouse. Once you're in assisted living, you don't have to stay there. You don't have to stay anywhere, by the way. But let's say, there was a little short-term stay for recovery because let's say your house has a lot of steps. You don't want to go into a nursing facility. You don't want to put in a stair glide at home, or maybe there's no one to assist at night. Maybe you seek out assisted living for your recuperation. Nice place, your own little apartment, meals given, everything's great, housekeeping's done, laundry, etc. Come and go if you want. It's handicap accessible. Now you can get your VNA over there to do some rehab for you to get you stronger so that you can manage those steps when you get home. Or plan, you can't just get a stair glide at, wiggling your nose like Bewitched. But, some things needs planning. Can't stay in the hospital, but you can't go home yet. You can't. So assisted living can be a nice alternative as well. Some people like it and decide to move in, sell their homes and give up that lifestyle and live in a different environment. So now I have a little bit of time left, and I probably gave you so much that you're maybe eating Tums right now. I don't know, or your head's spinning, but you're not going to figure it all out in this session. You're going to get little bits and pieces you might have taken from this. But we're always here for you. There's always someone, and you have to thank Miranda and the Goldstone Caregiver Center here, because they're also another resource for you. And I appreciate all the, putting this on for the community and having this awesome place, an awesome social worker, and your volunteers and other staff in the Caregivers Center that can assist as well with resources. And you don't have to, correct me if I'm wrong, right? You don't have to have a patient in the hospital to access your help.
Correct. We are free and we are available to the community. You do not have to have a patient involved in Nuvance Health at all. We are truly here for caregivers in the community. And Evie, thank you. This is a ton of information. I learned a lot too.
I didn't learn it all in one session either. It took me a lot of years.
Yeah, definitely. You mentioned, one question in the chat when you had talked about the 3 exceptions of going out. The question was, does haircut include manicure, pedicure, massage, and facial? I'm guessing not. That with, the religious and doctor's appointments.
Well, you know what? who's gonna ask, you know, like, I mean, to me, it's all the same.
Mhm.
You know, I mean, it's going to get a little bit more lenient too, because some people have to get, you know, there's some people that take themselves to doctor's appointments
Mm.
and they're like, I don't have anybody to take
Right.
me to my appointment. Where do I go? Well, there's Uber, there's Lyft, there's taxis. In some places, there's the Sweetheart bus. You don't have to be a senior for that. You can be disabled and younger, or you could be 60 and older for that. There's different, some towns have shuttles as well, but yeah, it's starting to get a little bit more, you know, as long as going out is taxing,
Yeah.
no one's going to ask you when you went to get your haircut, what else did you have done?
Good point. Very good point. Bundle your trip for the haircut.
That's it.
There was
Just
another.
just going to the mall or going out to eat is a big no-no. You start telling your aides, your VNAs this, they're going to say obviously you're not homebound. And one exception, Medicaid recipients, this is not fair at all, but people who are just on Medicaid or just on Husky and do not have that Medicare, there isn't a homebound restriction, which is crazy. But another thing, medical equipment in the bathroom, such as a raised toilet seat or a tub transfer bench or a shower chair, not covered by Medicare, covered by Medicaid. I guess people, if you're on Medicare, you don't have to use those devices. I don't know. Yeah, it doesn't make sense, but maybe one day they'll even out.
Yeah, yeah, hopefully. There are a couple more questions in the chat. One is, what goes into the determination of admitted versus observation status, and can it be appealed? It has a big impact on payment of skilled nursing facility services.
So I don't make that, I don't know specifically the criteria. The nurse case managers do that. My sister-in-law happens to be one of them in the emergency room, and she does that. She tries to determine that by catching certain people right from the beginning, whether it's going to be observation or inpatient. And sometimes it changes, but there's certain medical criteria that determines that. You're very, you can ask your doctor, your nurses, is this, if I'm staying here, I'm not going home from here, is this observation level or is this admission? During COVID times, again, we had this waived, but now that it's more people are vaccinated, there's less people in the hospital with COVID, it's going back to that 3-night stay. But inpatient level, there's either more testing being done or you're meeting, you have fevers, antibiotics are needed. There's certain criteria. Yeah, and you can't appeal an observation level. You can only appeal an inpatient level. And if you're Medicaid, state aid, you cannot appeal. It's only Medicare or managed Medicare that you can appeal.
Wow. Okay. Thank you.
Okay.
And another question, just to clarify that assisted living is paid by private funds. The VA may help.
The VA may help if, again, the person going in there is the veteran or a widower of a veteran, meets certain need for aid, then the amount of money that they give is about, I don't know, I want to say $12,000 a month. Maybe it's 14 now. I'm not sure what the amount is. But if you have a lot of assets, here's where the other thing is. I had a veteran in a nursing assisted living, sorry. He had to have less than, I think, $80,000 or so, and he had more than that, so it wasn't covered. So there's an amount too that, again, finances do play into what your choices are. That's one of the first questions I ask too. I hate that that healthcare has a lot to do with money, but that's the way of the world and we can't change it at this point. And the first thing I do when I assess someone too is, what are the finances? What are your resources? Because that will determine, are we applying for Connecticut community care? Can you afford a nursing facility? Maybe assisted living is the way to go, but how much do you have in assets? Maybe you can go home with a live-in or some home care to make up some of the difference in the lack of supervision or lack of, to meet some sort of need. May not be all day, maybe just 4 hours a day, 2 hours twice a day. So, we do have to look at that. And then we start taking our flashlight down the roads and seeing where you qualify for. And a lot of questions will come up during that time period of a social worker or case manager.
Yeah. Hi, Evie. Thank you.
Yeah.
I wanted to mention again the importance of, if possible, finding a good elder care attorney. An alternative to a reverse mortgage is something called a revocable trust, where you basically take over the finance. If you're married, you basically divest your spouse of ownership of anything if the spouse is the person who's in long-term care. And then the revocable trust, of which the spouse is the trustee, then becomes covered by the spouse's will. In other words, if anything happens to the spouse while the other person is in long-term care or nursing facility, all the funds may be used for medical care or nursing home care, but they don't have to be. In other words, the scenario that you described about, having a certain amount of money and then Medicare or Medicaid comes in and gets their hands on everything to pay for care without you're having a choice. If a certain kind of trust is set up, they can't do that. It's all up to the trustee. And in the case of the death of the trustee, it goes to the executor of the will, who can make the same kind of decision. So that was pointed out to me as an option here by an elder care attorney. There's a group called NALA, which is the National Association of Elder Law Attorneys. And they're listed on the web, and it's a very valuable resource for us old folks dealing with this kind of thing. So, and thanks for, I don't know how you make your way through these incredible complexities at all times. It's mind-boggling.
A lot of years of doing it, I think.
I know.
To figure out where you start with this, because, I've just heard so many different scenarios in my 30 plus years of social work that, it's just, sometimes I still hear of a new situation that comes up.
And you're not even old yet.
Thank you. Old enough for AARP though. I still get that newsletter. There's also something I just want to touch on in case there's any other questions first. I mentioned a formula in a nursing home where there's spouses. So they don't want to leave the community spouse destitute. Okay. The object is not put two people on Medicaid. Yeah. So they come up with the asset limit, right? There's a ceiling to the asset limit to where it could be split. Anything above that would go towards the nursing home. So if you look at my hands, this is the nursing home side. Okay. So let's say you have let's say you have $200,000. You're splitting it down the middle, 100. This side is being used up towards the nursing home person without touching your part. But if you have maybe above that ceiling, whatever the ceiling is these days, that would go towards the nursing home person.
Oh, okay.
Now, the nursing home person can spend that down without you touching yours.
All right.
But they can spend it down on an irrevocable funeral home trust. They can spend it down on buying you a car or fixing up the house for you or getting you a funeral home trust out of their funds, but they can't be putting you on a boat for a lovely cruise. So it's got to be towards the house upkeep or towards death, the inevitable planning that can happen. They could do that out of their half, plus paying the rest towards the nursing facility until they get down to $1,600 where they're active under Medicaid. Usually people, when they're on Medicaid, their income goes towards the facility. Social Security, pensions, etc., and they keep a small portion of that in their personal needs account. It's the last I knew it was $60 a month, right? Okay, but now what happens to this person over here? I may not have 100,000. I may have let's go to maybe 30,000, and I need that income because I'm paying mortgage, I'm paying a car payment, I'm paying credit cards, health bills, whatever. Let's say that person totally relies on that income. The state will then determine, what does spouse in the community need to pay for bills? And by the way, they look at everything except cable, because they figure that's, a privilege. I mean, it could be part of your internet though these days. Back in the day, cable TV was different than phone, but they'll look at your bills and they'll decide, hey, maybe you need to have that income, 100% of it, to help you stay in the community. Then the state's going to pay more for that nursing home. That income is to sort of subsidize part of that bill, because it's like the biggest outgo for the state budget right now is nursing facilities. It's like one or two. If you think of all the hundreds of thousands of people like across the state in nursing facilities that they have to pay for every day. But maybe you only need, the state only says based on what your needs are and what you have, your assets, maybe you only need part of their income, or maybe you're doing pretty well. You don't need any of their income. But I've seen people that I don't know how they did it. I saw a community spouse have like 110,000, and they still were able to keep the income from the spouse in the community, in the nursing facility. And he got a new truck, paid for both burial, irrevocable contracts, and put a new driveway in and a new roof on the house. So again, there is some kind of, formula. Now, the spouse in the community, the spouse in the nursing facility also has to have that half of the house transferred to you. That transfer is allowed to a spouse.
So is this part of Connecticut community care, all of this?
No, this is just going on Medicaid.
Oh, Medicaid. Oh, okay.
Yeah, state fund. The other way it can be transferred is to, like, let's say you're a child of a person in the community that's needing care. As long as you're taking care of them for at least 2 years and you're living with them, and that's keeping them out of a nursing facility for at least 2 years of that time, then it can be transferred to you.
Wow.
Or a disabled person in that home that's relying on that shelter. So again, there are some, it is complex. Oh my God, I know. It's so complex. So that's why you turn to us and we can say, hey, you should go, in this case, you should go see an elder care attorney. Or in this case, you should probably do this.
Yeah.
We can give some direction. Sometimes it gets a little legal and we will then recommend that. We won't say, hey, good luck, it is complex. Figure it out and tell me what you did. We don't do that, but we try to. There's some social workers that have more experience than others, and some don't know all of this. It took me years and years of experience. And I see Doris Catalano there. Hi, Doris. Doris volunteered for me for a while in the nursing facility, and she came to one of my caregiver support groups. So she's nice to see your name there. And Nancy, I know Nancy for a long time as well. So any other questions?
In order for those transfers to happen, do families have to go to court, or do they just apply to
It's usually a quick claim.
claim?
So some people have an attorney, just ask for a quick claim, see what their costs are. Some people want this whole, they want to charge you a ton load of money because they're looking at the asset that you're now going to have all to yourself, and they're going to base it on that. Some people will just base it on an hourly rate. I don't know, Carol's, what yours is, if you have any experience with this part, but just look at the different costs. Check with a few different attorneys on what they do, because some want to work on the Medicaid application for you too. You don't have to have an attorney do that. There are social workers out there that do it. There's facilities that will do it. There's specific companies out there that do it. You don't necessarily, there's some people that will do it for free, but yeah, just look what you're getting, look what you're paying for. You might just need one thing done. And they might want to do power of attorney and a will at the same time. That's great, but you don't need necessarily to have an attorney do power of attorney. You can have the papers just as long as it's notarized by someone and your witness is over 18 and you are of sound mind when you do your power of attorney, then you don't need an attorney for that either. But they do have the knowledge and they do have the paperwork too.
There are so many aspects of all of this. I want everyone to know too, that on the Goldstone Caregiver website, just like we're recording today's Zoom program, we have other Zoom programs that are posted that have been recorded the past 2 years. And a husband, wife, elder care attorney team did do 2 separate presentations that you guys can access from the Goldstone Caregiver Center website. One is on long-term care asset protection, and the other one is protect yourself with trusts. So I just want you to know that there's additional, Evie, you provided a tremendous amount of information, and touching on those is really important too. So I want everyone to know there's more in-depth detail on those 2 areas as well. Are there any, I know we're getting to the end of Evie's time. Are there any additional questions before we close out the program today? Oh, Carol put in the chat, NAELA, National Association of Elder Law Attorneys. Thank you for that information too.
That's great.
Thanks.
All right, well, if there are no more questions, Evie, I know you've got to run.
Perfect
Evie-
timing. Yep.
Evie Brescia.
Thanks, Evie.
You did
Yes,
a
Thank you very
fantastic.
much.
I have over
Yeah.
here, you know, the maternity is calling me, the rehab's calling me. So yes, I will be very busy as soon as I log off here, but thank you all for joining and taking part in the information you also have to add to it. It's great. But there's people out there, unfortunately, not a lot of people know of the resources. So thank you
Thank you.
very
Uh,
much for answering this and having me talk.
Evie, thank you so much. This is
Great.
valuable information. We appreciate it.
All right, you're welcome. Bye. Bye, you
Bye.
guys.
Bye-bye.
Take
Thanks, Evie.
care.
Bye.